अभी से रिकॉर्डिंग नहीं करो प्लीज. विल डू इट एट 9:28. कविता, हेलो. हेलो. आईटी कविता. कविता, प्लीज स्टॉप द रिकॉर्डिंग.
So, a very good morning to everyone. Dr. Poonam Joshi, welcome you all to our ACTRAC Head and Neck academic classes. For today, our speaker is Dr. Rahul Singh. Dr. Rahul is a consultant at Apex Hospital in Varanasi, and he will be speaking on the topic adjuncts for the evaluation of potentially malignant disorders of oral cavity. With this, I hand it over to Dr. Rahul. Dr. Rahul, please go ahead with your presentation.
Thank you, ma'am. Thank you for the kind introduction. And good morning, respected seniors and my dear colleagues. Today, the topic of my presentation is adjuncts for the evaluation of potentially malignant disorders of oral cavity. So, why the malignant disorders? Basically, this term oral potentially malignant disorders have come from the WHO in 2005. Initially, it was precancerous lesion, which has been defined as the morphologically altered tissue in which oral cancer is more likely to occur than in its apparent normal counterpart. But in 2005, it's been found that this lesion, the precancerous lesion, has been shifted. The term has been shifted to the disorders because first, all the precancerous lesion doesn't turn to malignancy, and second, the patient who are having this precancerous lesion or OPMDs, they don't develop malignancy at the initial site of presentation of the lesion. Hence, the term was removed, and the new term is coined as disorders. So now these disorders, precancerous disorders, are the risk of malignancy being present in the lesion or condition either at the time of initial diagnosis or any time in future the patient may develop. Now the OPMDs are basically a chronic process, and it takes around 5 to 15 years, and most commonly it occurs in Asian and the South American population, with Asian of 10.5% and South Americans of 3.9%. And more commonly, it is prevalence is more in men, around 60%, and average age of at which the lesions were found around 50 to 59 years. And in 1 to 5% of population, the OPMDs may be found in the younger generations. And as this is the Western data, as it says, it's more common in from buccal mucosa to tongue to the palate, but in our South Asian countries, it is more common in the buccal mucosa. And transformation rate of OPMD. So for lichen planus, it is 0.28%. For oral lichenoid reaction, it is 0.57%. For leukoplakia, yearly malignant transformation rate, that yearly 1.5% chances of getting malignancy raises. So it adds up per year. And erythroplakia, it is 2.7%. And proliferative verrucous leukoplakia has the highest percentage of 9.3% yearly malignancy transformation per year. So now coming to the topic, why we are discussing the OPMDs. OPMDs we are discussing because we are treating cancers, but they in the Western population around 60%, 40% patients are coming at late stage, but in our part it is around 60 to 70% people are coming at late stage. So the basic aim, I feel the aim of this lecture is to guide for primary healthcare providers to identify the OPMDs and do the other treatments and or the referrals needfully. So there are three main adjuncts: vital stainings, oral cytology, or visual adjuncts. So vital staining, basically in this, there are multiple stains through which they stain the oral mucosa, and that will help in identifying the high risk lesions. Same goes for the oral cytology. As we know, there is scrap cytology and transepithelial cytologies. These also will be scrapped by a primary health provider or the people at the primary health or secondary health centers. But the final evaluation of cytology may require some expertise. Now, the visualization adjuncts, these adjuncts are basically been nowadays are more focused because what we want is to identify the lesion at the peripheral site. So we want a person at the distant rural site or at the town level to identify this lesion, and that doesn't require much expertise. So to make this happen, we are going with advances of multiple chemiluminations techniques or the autofluorescence imaging techniques, so that these are the adjuncts for making the identification of OPMD easy, and it doesn't require much expertise. So in this, the visual adjuncts, there are chemiluminescence, autofluorescence imaging, narrowband imaging, confocal microscopy, high resolution microendoscopy, elastic scattering spectroscopy, diffuse reflectance spectroscopy, Raman spectroscopy, fluorescence spectroscopy, and optical coherence tomography. So as I have discussed, these are the adjuncts. Now the vital stainings, we are coming to the first of its kind. So the dye used are basically toluidine blue, Lugol's iodine, methylene blue, or the rose wingle. The toluidine blue stains dysplastic epithelium, making them royal blue. Now, this toluidine blue basically has affinity for DNA nucleic acid, and that's why it is called as the nuclear staining. Why it is being used? It helps to guide the biopsy site selection at the baseline. So if the patient have multiple lesions in the oral cavity, this will help to guide from where is the more significant lesion from where they have to take the biopsy. It also helps to identify and map the high risk disease prior to surgical excision, and it also can be incorporated for the long-term surveillance. Now, the toluidine blue basically is a toluenium chloride, has been used as a vital staining for more than half a century in oral medicine. And this is a cationic metachromatic dye with a high affinity for the acidic tissue components such as nucleic acid. An area of the mucosa that potentially shows abnormalities or dysplastic or anaplastic cells can retain this stain and manifest as a dark blue. So as we can see in this imaging, in the picture, the toluidine blue has been picked up by the lesion. And how is the process to do it? We initially pre-rinse with the acetic acid. Then we go and rinse with the water. Then the dye is applied 1% toluidine, which is commercially available. And then again, post-rinse, we need to do a acetic acid rinse followed by water. The observed mucosa or the staining will be around having sensitivity of 86% and specificity is quite low of 68%. So these methylene blue and rose beagle have a similar staining profile and the performance as toluidine blue. But the Lugol solution, this Lugol solution is basically a it has affinity for glycogen granules in the cytoplasm of the cells. So it stains the cytoplasm of the cells. And as we all know, the dysplastic cells or the malignant cells have a high glycolytic rate. Hence, this won't stain the lesion. So the Lugol solution, it stains the normal non-keratinized oral mucosa. It doesn't stain the lesion, and this normal mucosa will get dark brown color. So the vital staining can be deployed at the dental clinics or the primary health centers and or the tertiary center required for minimal equipments. And it is a potential for both false positive and false negative rates are quite high. Now the third is the rose bingle. This is the tetraiodide derivative of fluorescein, is a xanthine dye that has photosensitive properties, and it stains the dysplastic degenerate cells but not the healthy epithelium. Now coming to the second modality called as cytology. Cytology refers to the study of cells for diagnostic purpose. And there are three main types of cytology we use. Exfoliative cytology. It is the study of cells from the epithelial surface that are been obtained by a scraping by a spatula or a specialized brushes. Second is the transepithelial biopsy or liquid-based cytology. These are the modified brushes with firm bristles, and these are used to obtain not only the surface but also the full thickness of epithelium have been tried to scrape from the lesion, and then they are evaluated. And as FNAC, we all know it is a technique used as a needle to obtain the cells, and then they are processed. Also in this, there is a liquid media. Multiple articles have mentioned the liquid media. In this, the cells are kind of stored in the liquid media, and they can be used, if at all possible, as a cell block in future, because that will give a high cellular yield. Now, procedure to do it is remove the surface debris from the mucosa. In exfoliative cytology, the mucosa has been scraped, as I have discussed before, with a spatula. In transepithelial biopsy, a modified brush is used to obtain a full thickness epithelial sample. The cell obtained are smeared evenly onto the labeled microscopic glass slide and fixed with 95% alcohol. The slides can be stained with the pap stain. And these are the cytobrush which are used for the exfoliative cytology. Now, the advantages and there are a disadvantage of every procedures. Cytology it is a simple chair-side procedure, so it can be done at primary health centers or dental clinics. It is a non-invasive and painless. Local anesthesia hardly required in some procedures, and bleeding is minimal or almost absent. Disadvantages are the pathological changes in the deeper part of the epithelium may not be represented, as we are taking only the epithelial surface. The stroma is intact, and relationship between the cells and the epithelium architecture cannot be studied, as we are just scraping the tissue. We are not taking the whole chunk of tissue. Usefulness of this procedure is cytology is a simple procedure and can be performed by frontline healthcare workers or general dentist, and further laboratory setup or the special opinions are required for the diagnosis, as I have discussed before. The sensitivity of oral cytology is around 90%. It's a pooled sensitivity, and the specificity is around 94%. So the cytology smears can, however, be further studied using a quantitative cytomorphology, nuclear DNA content analysis, immunohistochemical tumor markers identification, and molecular analysis. They can also be used for the epigenetic alteration to check for the epigenetic alterations and the LOH, loss of heterozygosity, and in case of microsatellite instability also can be checked with this, and also the restriction fragment length, polymerism, and other molecular markers can also be used to be done by these procedures. Now, the cytomorphometry, it is a computerized assisted analysis of the cells which are being taken from the cytology. These have generally in this, the morphological alteration in the cell is picked up by computerized assisted system. In this, a computer will assess the morphological alteration in the cells, and the reporting is of three types. First, it is positive, negative, or atypical. So the positive, it means there are dysplastic cells are present in the given sample. Negative, in which they didn't found any kind of morphologic alteration in the cells. And atypical is the third kind of result you may get in the cytomorphometry, is like the morphological alteration are there, but they are not significant. So these are called non-specific alterations. Now, going to the third part of our adjunct, these are the visual adjuncts. These are optical spectroscopy. Optical spectroscopy refers to information about the morphological and biochemical changes, and it shows progression of oral cancer by exploring the optical phenomena. So, as we all know, each cells in the body has their own optical phenomena that they will emit some kind of some kind of fluorescence when they are activated by a certain kind of light source. So in this, coming to first one is the chemiluminescence. Chemiluminescence involves the visualization of a chemical reaction between the acetyl salicylic acid and hydrogen peroxide. Basically, what we do in this chemiluminescence is we give capsules, and the patient is asked to chew the capsule, and this capsule has two compartments. In one compartment there is a hydrogen peroxide and other has a acetyl salicylic acid. So we ask the patient to chew it. The patient will chew this, and in that they will the hydrogen peroxide and acetyl salicylic acid will have reaction, and that will make a bright blue light emission in the oral cavity for 8 to 10 minutes. And during this period, we take a light source and observe the oral mucosa, and we can find where all the morphological or dysplastic changes are there. This procedure can be used for identification, visualization, or monitoring of OPMDs. So you can identify the OPMDs, we can visualize, and even you can, in a sequential basis, you can have a monitoring of OPMDs as well. The limitation of this procedure is like it has a limitation that it takes the inflammatory tissue as well in the bright form. So it is difficult to differentiate between the inflammatory and the dysplastic or the malignant cells. The procedure involves rinsing with the acetic acid solution and visual inspection using a disposable handheld light source, which emits blue-white light. As we can see here, the normal mucosa will have a blue-white reflection, whereas the dysplastic abnormal mucosa will have fluorescent pattern associated with the around blue to greenish color. So the strength and limitations of chemiluminescence is it is simple to use and non-invasive procedure, provide real-time result. You can get result on immediately after doing the procedure, and it can be performed by any operator after short training, which I most likely not agree to this point, and the limited operator variability, because it is a subjective phenomenon. You don't get any quantitative things like which is a malignant or which is a dysplastic cell and which is a normal tissue. There are operator variabilities are there. So limitation is it needs a dark environment, high recurrent cost is involved in the light source, low specificity for dysplasia, and inability to objectively measure the visualized result. Usefulness of chemiluminescence can be performed in a primary care setting like in a dental clinic or PSC center with a minimal equipment. However, the cost incurred needed for the specialized interpretation are its limitation. The sensitivity and specificity also could have little bit lower range, with a sensitivity of 74% and specificity still bad, like 47%. Then the autofluorescence, as I have discussed, autofluorescence imaging uses devices that generate a blue-violet light that excites tissue fluorophores. What are the fluorophores? They are the FAD, NAD, and NADH. These are the flavin adenine dinucleotides. NAD is the nicotinamide adenine dinucleotide, and hydrogen is NADH. Collagen, elastins, and reveals a visible fluorescence emission. So in OPMDs, these all properties of a normal tissue or the mucosa get weakens because they are all collagen breakdowns are there, and there is altered in the metabolism of NAD and FAD, which leads to the epithelial thickening and increase in nuclear cytoplasm ratio, and neovascularization and increase in vascularity lead to the alteration in the normal tissue autofluorescence characteristics, and this is the basis for the AFI. So the autofluorescence imaging is a technique that can be performed with minimal equipment and can be performed at a primary health center or dental clinics, and the imaging can collect required but it requires the interpretation by a specialist. The pool sensitivity of autofluorescence is 75% and specificity of 50%, for OPMDs versus non-dysplastic lesions, but it has a relatively better sensitivity for the malignancy. So the pooled sensitivity of AFI or autofluorescence is 96% for the oral squamous cell carcinoma compared to OPMDs, which is only 75%, and specificity is low in both, around 58%. Hence, it can be used for some, like in malignancy, it can be used, but the gold standard till date is always been a visualization and palpation. So visualization, palpation, and the biopsy are till date the gold standard. These all are the adjuncts. They are currently, as if now, are not replace the standard procedures. Now, Wellscopy, this is a much discussed topic. Wellscope generally, as we can see here, these Wellscope is work on the same principle of AFI. And as we can see in the image on the right, how well it has diagnosed the ulcerative lesions. Then the one more in the visual adjuncts is called as multispectral fluorescence and reflectance. In this, what they use, three types of light source are used: white, violet, and amber. This white and violet are used for the in this white and violet light, the lesion will appear as a darker and pale green, whereas in amber, the vascular, it takes the vascular architecture over the tissue. As we can see in the greenish image above, on the mid image, it is, I cannot move my server here. As we can see the image above, in the middle, there is vascularity is preserved, and on the right side, the altered vascularity, which can be seen with the multispectral fluorescence and the reflectance. Now, coming to the other modalities which are available is the narrowband imaging. Narrowband imaging, it's evaluate the surface texture and the pattern of vasculature on the mucosa. So it uses two types of narrowband lights. These are blue-green spectrum, which is 400, which uses 400 to 430 nanoman. And for specific vasculature, and the blood vessels appear brown in this. Green spectrum uses to 525 to 555 nanometer, and for thick, this is used for the thicker vessels in the submucosa, that is the deeper vessels. And the oral squamous cell carcinoma, oral pre-malignant lesions may exhibit abnormal neovascularization, as I have described before, and it has relatively low sensitivity of 31%, and specificity is quite high, reasonably high at 90%. Now, the second modality is the confocal microscopy. As I can show you the images of narrowband imaging, as we can see here, how a small lesion on the lower GBS can be seen on the scan, which has been on the narrowband imaging. And this is how it's been done. And the confocal microscope uses a point source of light, and it rejects the outer sources so that it will go deeper, and it neutralizes the outer source of light while providing the ability to image deep into the tissue with a high resolution. The confocal microscopes can image superficial tissue up to a depth of 200 to 300 micrometer, and it has a sensitivity of 50 to 100% and specificity around 75 to 100% in some studies. High resolution microendoscopy. High resolution microendoscopy utilizes light emitting diode. It is basically using a fiber optic probe connected with a light source, and it detects the fluorescence in the cell stained by a topical dye called as the proflavin. And it has a sensitivity of around 85 to 95% and reasonably good specificity of 80 to 90%. And these are the imaging. As we see, the high resolution microendoscope is been placed. A fiber optic probe is directly, after staining the tissue, it can be placed directly on the lesion, and it will give a magnified image which can be stored. Also, this imaging can be done without staining the mucosa. So it can be done in both ways. Either you stain in some articles they have said to staining has been proved counterproductive as well. So we can just see which way it's work. Then it comes the elastic scattering spectroscopy. Elastic scattering spectroscopy detects reflected light that has been scattered through the tissue while differentiating the measurable signature spectra from the different depth. And it has a sensitivity of 72% and specificity of 75%. And the other modality comes is the diffusion reflectance spectroscopy. The information about the tissue absorption and scattering is due to parameters such as hemoglobin concentration, oxygenation, and increases epithelial thickness and the nuclear cytoplasm ratio, and which alters the vasculature. And this work on this principle, and sensitivity is around 80% and specificity is around 86% in this. Then comes the Raman spectroscopy. Raman spectroscopy is based on detection of inelastic scattering of light with a monochromatic laser light source hitting the tissue which generates significant spectra equating with the molecular composition of the cell or the subcellular level. So this light source will check the molecular compositions. According to that, its spectra of light diffuses or the scatters, and it has a sensitivity of 77.27% and specificity of 86%. Then comes the fluorescence spectroscopy. Fluorescence spectroscopy captures the spectra remits by the endogenous tissue fluorescence and the laser-induced fluorescence, and xenon arc lamp are used as a exciting source, and the spectra are recorded with a varying excitation wavelengths and spectroscopy devices. And this has shown a good sensitivity of 93% and specificity of 97%. And then it comes the optical coherence tomography. The optical coherence tomography works by the interferometric depth resolution detection of elastic light scattering, and it can image tissue several millimeters deep, around 2 millimeter up to deep, and has a high resolution of approximately 1 to 2 microns. And this can be used for the oral cancer in situ or oral submucous cell carcinoma versus the non-cancer, and which has a sensitivity of 93% around and specificity also around the same. So after this, there comes a predictive biomarkers in the blood. These are the protein biomarkers of origin of proteins, glycoproteins, and non-proteins. And in some cases, in certain studies have found that the squamous cell carcinoma associated antigens, inhibitors of apoptosis, IAP, cytokeratin fragments, shown to have a sensitivity of around 81% in detecting oral squamous cell carcinoma. And the annexin A1 is a recently identified peripheral blood in the peripheral blood by RT-PCR has been showing the proposed to potentially diagnosing the biomarker for oral squamous cell carcinoma from the blood. And the last, it comes the biomarkers from the saliva. As the saliva is the source which has been constantly in touch with the oral mucosa, so any alteration in the oral mucosa could alter the composition of saliva, which has been proven. And these are the proteomics. Genomic targets can be analyzed. Cytokines IL-1 and IL-6 are mostly increased in the patient having dysplastic or malignant cells, and as well as the metalloproteins, cytokeratins, mRNA, and DNA transcripts. So these are my references. I'd like to thank ma'am for the opportunity. Thank you so much.
So thank you, Dr. Rahul, for a comprehensive presentation. I think it is quite a technical topic with so many modalities involved, and so many methods to involved, and it was quite a comprehensive lecture. I think among us is, I just saw is, sir is there? Sir, Pankaj sir is there? Hello.
Yeah, I'm here, Poonam.
Sir, good morning, sir. Sir,
Good.
would request your comments and points, sir.
So very well presented, Rahul. And
Thank you, sir. Good
I'm
morning.
sorry, good morning, good morning. So I'm attending for the first time, but this is a very excellent forum where a lot of people from outside can make their presentation. They can harness the skill of making presentation and getting critical comments from people. So that's also a very important learning skill. On your presentation, I would say that yes, you did a fantastic job. Only thing is that whenever you make a presentation like this, there is Cochrane analysis. Now, what Cochrane analysis does, it goes on the evidence-based recommendation for everything, whether it
Yes.
is a library-based marker, whether it is diagnostic adjuncts, whether it is community screening, all that. Correct?
Yes, sir.
So, if you had added those Cochrane reviews, then it tells us the independent evidence-based recommendation for all of those so that students can take a take-home message.
Yes, sir.
So one is that giving the whole gamut that you have, and then you should end with that what is the current evidence for that.
Yes.
Similarly, whenever you are making a presentation, it is always better to have a perspective implementability. Implementability means that I may have, say, when this qualitative cytometry was there, what we used to call brush biopsy. Now, brush
Yes, sir.
biopsy technically is a very simple thing.
Yes,
Simple
sir.
thing as in you have a small brush, you rotate it on the specimen in as in tumor, put it into the slide and put the slide into the computer and it will tell you the report.
Yes, sir.
There can't be anything simpler. But the
Yes.
problem was that each diagnostic, this ORA CDX biopsy would cost around 750 crore, 750 rupees. So that becomes a big difficulty.
Yes, sir.
So A, what is evidence? B, what is efficacy? And third, what is the implementation? So these are the factors that are very, very critical in implementation.
Yes, sir. Yes.
Similarly, you have to also understand like implementability. There are two settings. One setting is whether it will work in a dental clinic. The
Yes, sir.
other setting is whether it will work in the community. Now,
Yes.
well scope can work excellent in a dental clinic, but well scope will have a great difficulty into the community. The
Yes, sir.
reason of the false positivity. Now,
Yes, sir.
false positivity is worst when health workers are using it, but when doctors are using it, false positivity will be low. So these are the factors that we need to take care when we are discussing about such an important thing.
Yes, sir.
And what is most critical is to understand what is the best evidence that currently we have. The best evidence that we currently have is for the visual inspection. Now,
Yes, sir.
visual inspection is the only thing which has been tested in the community, which has
Yes.
reduced the mortality due to oral cancer in a population where oral cancer is a public health problem. So,
Yes.
excellent presentation. Good job.
Thank you so much, sir. Thank you so much.
Thank you so
Thanks.
much, sir.
So if there are any comments, if there are any questions, you all can put in the chat box and we can take them one by one. I think Rahul and everyone what Pankaj sir said just now, that Cochrane meta-analysis that shows the various, which
Yes.
Rahul presented beautifully, the various modes of these adjuncts, the various ways to diagnose. So among them, when they saw the pooled sensitivity and specificity, what I remember is that was highest for the, like sir said, for the cytology. But it again has its inherent problems. And with that, the most of the methods had sensitivity of around 70 to 80%.
Yes,
And
sir.
the specificity was again varying, and it was highest with the cytology. So just to
Yes,
add to
that's
that,
why I
what
told
sir
in that key biopsy and the visual inspection and palpation are till date is the gold standard. So that
Yes,
is
Rahul.
still
So
there.
what sir also said, and you rightly
Yes.
said, is the again the visual inspection and palpation. But these adjuncts have their role when we are not very sure, because the name is adjuncts itself. So if there
Yes.
is any issue, we are not able to have a clear idea where exactly to take the biopsy, or there are multiple lesions. Then in those cases, they can be really helpful.
Yes.
So if there are any questions, we can take in the chat box for anything for Rahul or for sir or for me, we can take it. I think, Rahul, we had a long discussion, and I think if there are no more questions.
Okay, ma'am. Thank you so much, ma'am.
So it was a great presentation. I understand the limitation because it's a vast topic, and each and every modality actually is a topic, is a research in itself. So when we
Yes,
talk about Raman spectroscopy at ACTRAC, we have a whole lab for that. When we
yes,
are talking about confocal, it's a different investigation altogether. NBI itself is a big this research is going on and work is going on. So, but still, you helped us to understand it in such a small time. I think there is one question, Rahul. In actual practice in India, we mostly see patients report with advanced diseases. So, won't it be more difficult to implement these methods as surface level will have more necrosis? Can you read the question, Rahul, in the
uh,
chat box?
yes, ma'am. Just a minute.
I will
Uh,
read it again. So, in actual practice in India, we mostly see patients report with advanced diseases. So, won't it be more difficult to implement these methods as surface level will have more necrosis?
Ma'am, actually, these adjuncts won't be required for the advanced diseases, to be frank, because these are basically for OPMDs. And when you have already a disease, then obviously you have to go ahead with cytology or biopsy, whatever is there. So these adjuncts are to identify the disease beforehand, not the after in the advanced stage.
Correct.
So
So I think we need to understand that these adjuncts are for the lesions where the we are not sure clinically also about the diagnosis. Like why Rahul presented in the first two slides is the what are PMDs. So these are the potentially malignant disorders which may be confusing because again this is a whole gamut of these diagnoses. This can range from your leukoplakia to erythroplakia to OSMF to lichal planus, and the list keeps on going. So many a times there are similar findings like leukoedema, your candidiasis may also look like that. So in those cases where you are confused what should you do, these adjuncts can be of some help. But having said that, like Rahul said, it is not for frank malignancy, and especially for advanced malignancy where there will be a large lesion, because advanced means stage 3 and stage 4. So you don't need it for those cases. You need it only for the cases which are usually very early oral cancers where you are confused, very surface level lesion, very small ulcer, or a small lesion. In those cases, it may be useful.
yes, ma'am. There is one more question. What is false positive result and how to prevent that? False positive, it means you person don't have a malignancy and you have done a test which shows a malignancy. So how to prevent that? Basically, as sir has also told, the visual and palpatory methods are the one which are still considered as the gold standard. And there are, as I have mentioned in each results, that what is the false negative and false positive percentage of a test of having the result. So if we have a doubt of having a false positivity, we have to go ahead with again with the if you biopsy. That I think that should be the way. Ma'am, your opinion in that?
Yes, I think false positive means we are getting positive even though it is negative.
Yes,
So
exactly.
it is. I won't say it is very common. The false
Yeah,
positive results are usually uncommon. I would say it is other way around. False
yeah,
negative.
yes,
So again, I actually don't have much experience, like I said, because we come across more of false negative than false
negative. Yeah,
positive results.
we come about false negative and we go and again do the biopsy with the
Do
deeper
the
tissue.
biopsy. Correct. Because so suppose it comes positive, what happens is suppose it comes positive and it is false positive, but how do we know it is false positive? We'll only come to know because if we remove the specimen and then we correlate with the final HPR and then we come to know it is false positive. That would be the way, because false
Yeah,
negative
yeah.
would be the way to go. Other question is frozen section analysis, is useful for repeat for the pre-malignant lesions. Again, I would say no frozen section because it will be only assessing a small portion. Because suppose in when they do they for the regular analysis they only make one or two slides.
Yeah.
So usually the frozen section will not make much of difference. They will not be able to tell you. The other thing I would say, it is not about the frozen section. Even for your these pre-malignant or potentially malignant disorders, usually it is a clinical diagnosis.
What we are trying to see here is that if some of this area is transforming to frank cancer, that's the point. See, suppose you have a leukoplakia, and most of the time you can't make the diagnosis of leukoplakia on biopsy, either on frozen section or on HPR, because it is a clinical diagnosis. But what you can get is you can get some sort of dysplasia. So if you get, suppose, severe dysplasia, you get a carcinoma in situ, then it makes a difference. But if you get nothing, you get hyperplasia or something, that doesn't help. So with this, what I'm trying to tell you is, for that potentially malignant disorders, we have to actually see where exactly to take the biopsy. And that's why this we discuss so much about the role of the adjuncts, because these potentially malignant disorders, as the name suggests, will not transform into frank cancer always. They may remain stable for years, or they many a times disappear also, which we have seen in cases of leukoplakia. So it's actually a very confusing thing. That's why this all discussion is going on. And frozen section has no role in the diagnosis of potentially malignant disorders, either per primum or in the repeat setting. Frozen replaced by high micro endoscopy. Any comments, Rahul? Can we do micro endoscopy?
By microendoscopy, we can see deeper in the tissue, but as you have said, frozen has no role and in the pre-malignancy setup. And microendoscopy, you can see the dysplastic changes at all, but it is not frozen. It's not like a frozen thing. Ultimately, you have to do the biopsy if you have a doubt. So that is the thing. Microendoscopy will never replace the biopsy in future.
Exactly.
I don't know, but current scenario.
No, I agree with you. So see, what I like, Pankaj sir said, we have to take a message through the lecture, and the message would be that these adjuncts are actually to identify the site where there may be very a malignant transformation or a very high risk of malignancy. So that is the basic aim of the adjuncts, and ultimately your treatment will depend upon the final report, and obviously your clinical assessment also. So they adjuncts, as the name suggests, they are guiding you, but they cannot decide for the final treatment. Final will be ultimately a biopsy, and if it comes positive or a severe dysplasia, carcinoma in situ, you have to plan accordingly. Or it comes as a hyperplasia, mild dysplasia, you can plan accordingly after discussing with the patient, depending upon the site and depending upon the risk of malignant transformation rate, which Rahul had shown initially in the slide.
Yes, ma'am. So basically, aim of this discussion is to catch the disease early as possible. So in that, we are getting adjuncts for the, like suppose someone sees a patient and they say it is a leukoplakia and they leave it and it transforms into malignancy. For that, in that, if you do a stain or if you do a microendoscopy or whatever adjuncts you take, in that you diagnose that, catch the disease early. So the basic aim is for the disease, catch the disease early, and as well as for the follow-up as well. You can keep a record in that.
So Rahul, there is one more question. If there is an apparently pre-malignant lesion and on biopsy and also on repeat biopsy, it comes out as focal atypia, what should we do? Should we go for a wide local excision with frozen, or should we go for wait and watch?
I think in this, the ladder of escalation is like if there is mild dysplasia, moderate, and severe. So mild is considered as a low risk, whereas moderate and severe both are considered as high risk features. So that is the way we go around. So
correct. So I would put another point also. What Rahul said is exactly right. So one would be your biopsy, if what kind of degree of dysplasia you are getting, and another would be you have to see the high risk features. So if you see it is a lesion which is I think we all are aware what are the high risk features. We had the previous class was on the detailed this discussion about that. So that if the lesion is on the tongue, this has been for some time, there is no habit, if or floor of mouth, if you see there is a leukoplekic patch, there is proliferative varicose leukoplakia, which had the highest yearly MTR rate, which Rahul had shown. It was around 9.3%. So if you have these features, then you have to do a biopsy. And then if you get dysplasia or even mild dysplasia, but if these are clinically, these are high risk factors, you can go ahead with some margin. Again, that's a controversial topic, that what should be the right margin in potentially malignant disorders. You can remove them and keep them under observation. But if you think, again, I would say it is a mild dysplasia, it is the homogeneous leukoplakia, it is in the buccal mucosa, patient is compliant, he is going to follow up, you can keep under observation. So
Yes.
there can be like these things. So there is no right or no clear cut way to go ahead with the PMDs. It's a confusing topic. That's why I wanted to have some discussion about it, because like for oral cancer, once there is oral cancer, you have to operate, and then depending upon the HPR, you have to decide for the adjuvant treatment. But the PMDs don't work like that. Why I said, I will just enumerate these points once again, and then if there are no more questions, we can conclude. One, the PMDs, they are a clinical diagnosis. So your clinical diagnosis by the treating clinician makes a lot of difference. Then there is different varying MTR, that is a malignant transformation rate. Then third, they can be actually diffuse. They can be like at various areas. So in there is a lot of research going on to find out where is this malignant transformation rate is going on. Okay. Then many of these PMDs, especially the leukoplakias, may remain stable for years. And then there is naturally morbidity of the surgery. And then the patient compliance. If the patient, once you have counseled old patient, 70-year-old, he will never come back. The family is not ready to bring him back some 50 kilometers from the rural village. You remove it and send and tell them to come after 3 months, 6 months. But a young patient who has a buccal mucosa lesion without any habit, and it will make a lot of difference to his or her life. And then the patient will come regularly for follow-up, will follow the rules. Then you can keep under observation. So I think these all points you have to consider when you are trying to diagnose, understand, and manage a PMD. Anything else, Rahul, you would like to add?
Ma'am, just I think from the chat box, as you can see, the people are more concentrating on the pathological features. But as you have correctly added, key it has to be along with the clinical radiological features as well. Clinical finding and palpation and inspection has no replacement till date. So it has to be
Exactly.
combined with this.
Exactly. So last line. So again, I would like to reiterate the fact that PMDs is a clinical diagnosis. You can't make a diagnosis of PMD on HPR on
Yes.
frozen. Only thing why you are doing biopsy is to understand the degree of dysplasia, understand the if there is carcinoma in situ or there is frank cancer. Which is diagnosing oral cancer. It is not a it is not a pathological diagnosis. That's why the management of these PMDs is challenging.
Yes.
So that's the point. So please take this message that it is a clinical diagnosis, but there are adjuncts which can guide us in diagnosing and understanding where exactly to take biopsy. Biopsy comes like dysplasia or positive, we have to treat the patient, but again we have to talk to the patient and we have to understand patient compliance. So with this we sum up today's lecture. Rahul, thank you once again.
Thank
It
you.
was a
Thank you
great
so much, ma'am, for
lecture,
the
and it
opportunity.
was again a very technical topic. So thank you for completing it in half an hour. Thank you so much for
Thank
all
you.
the active participants. Thank you so much.